answer some of your questions at the end. So let me see if I can scroll down here. So the gastrointestinal tract extends from the mouth all the way to the anus, and the structure that cancer can develop in any of these structures: esophagus, stomach, small or large bowel, or the associated organ, the liver, pancreas, a gallbladder. Let's see. Risk factor of GI cancer development. Most important is smoking, excess weight, poor diet, physical inactivity has all been implicated in cancer death in the United States. I'll talk about smoking. Tobacco use is the most important preventable cause of cancer. 30% of all cancer-related death in the US are due to smoking, and patients who are smoker lose about 30 years of life due to tobacco use, and this includes, death from cancer, unfortunately, and due to other related tobacco-related illness like cardiovascular disease, MI, etc., like heart attacks. Some infections can be associated with cancer, and this is a small list that I put up here. For instance, HPV, human papilloma virus, can be associated with cervical and head and neck cancer. The hepatitis B virus, hepatitis C virus can be associated with hepatocellular carcinoma, which is basically cancer of the liver. And H. pylori bacterial infection can be associated with gastric cancer, specifically lymphoma of the stomach, cold mouth lymphoma. Other risk factor, physical activity. It's associated with decreased risk of many different types of cancer being active. In a large meta-analysis involving about 50 studies, 24% reduction of risk of colon cancer when comparing the most active versus the least active individuals. Obesity, excess weight is associated with increased risk of cancer, and weight loss method, including bariatric surgery, have been associated with decreased cancer risk. So we do recommend, being active and try to lose weight. Diet, the 2020 American Cancer Society guidelines recommend a healthy diet, rich in vegetables, fruit, whole grain, essentially like a Mediterranean type diet, limiting the processed food like cereals, sugar sweetened beverages, and refined grainy products like pasta, white bread, etc. What are the symptoms of GI malignancies? Unfortunately, most of the time, patients don't present with symptoms, and the symptoms don't develop until the cancer is more advanced. And that's why we recommend screening, specifically with colonoscopy for GI cancer, detect rectal and colon cancer, starting at the age 45. It used to be at 50, but it's reduced now to 45. What are some of the common symptoms that patient can experience? For esophageal cancer, patient would describe what is called dysphagia, difficulty swallowing, eating, and drinking. Gastric cancer and pancreatic cancer can present with abdominal pain, weight loss. And colorectal cancer can present with constipation, change in the bowel function. The patient can experience bleeding, and sometimes patient can have iron deficiency. Sometimes, me being as a hematologist, also I get referral for iron deficiency. And part of the work of the patient above the age of 50, I send them to get GI evaluation. So these are some of the symptoms. Screening. So the idea of screening is, for instance, most colorectal cancer start with adenoma, called adenomatous polyp, that progress from small to large, and then dysplastic changes can develop on this polyp and then lead to carcinoma. And this process takes about 10 years to develop. And screening for colorectal cancer can improve prognosis by detecting an early stage cancer that we can easily treat and hopefully cure. And the recommendation for now is for average risk patient to start screening at the age of 45 by doing colonoscopies. How's a GI cancer diagnosed? We have multiple methods to diagnose it. Like if a patient have gastric cancer or abdominal pain, you can go with a scope, EGD. Exchange in bowel function, you do colonoscopy, you look for colon or rectal cancer, you take biopsies, and you obviously do imaging studies like CT scan to detect if there is any tumor anywhere in the body. How do we do the staging? We do a history and physical. We pay attention to any enlarged, lymph node. We get our CT scan, contrasted CT scan. This is, standard for all patients. PET scan, depending on the cancer. For esophageal cancer, we do PET scan. For instance, MRI depends on the cancer type. For rectal cancer, we do MRIs. Endoscopy is sometimes we need to know the size of the tumor and the extent locally. So we do what we call endoscopic ultrasound, and we measure the tumor. And we also send for tumor marker. So the staging of cancer, we utilize what's called the T&M staging system. T stands for tumor, and the tumor, we assign number 1 to 4, 1 being small tumor, 4 being a larger tumor. Usually 4 is a locally advanced tumor that, attach or invade into local structure. N stands for node, and 0 being no node involved, 3 being, many nodes involved. M stands for metastases, and 0 is no metastases, 1 having, metastatic disease. So this is the T&M that we use when we stage cancer, and then based on these numbers, we come up with the group staging. This is what we tell our patients, that you have stage 1, 2, 3, or 4. This is group staging, stage 1 to 4. 1 is localized tumor, early tumor. Stage 4 is metastatic tumor that left the organ of origin, went to other organs. And then we talk about treatment. So treatment for, it's not like one size fits all. We do what we call multidisciplinary team approach. So we have a medical oncologist, surgical oncologist, radiation oncologist, and with the association with the radiologist and the pathology team, we follow what's called the NCCN guidelines. This is the National Comprehensive Cancer Network guidelines. And each patient is different. Each cancer is treated differently. Each stage of the cancer treated differently, and each patient actually is different because the pathology, the tumor profile is different. So, for instance, a patient with esophageal cancer or rectal cancer that are locally advanced, we treat with upfront radiation and chemotherapy to shrink the tumor, then followed by surgery. Patient with colon cancer can go for surgery. And if it's just a stage 1 or 2, the surgery can be curative. That's it. They don't need anything. More advanced disease like stage 3 colon cancer need chemotherapy after their surgery. So so essentially surgery, if it's, we can go without any treatment if the tumor is just a small tumor that we can just take it out. Radiation we implement depend on the stage of the tumor. Chemotherapy works by killing all the rapidly dividing cells, whether it's cancer cells or normal, body cells can affect it. Immunotherapy, we utilize it, especially for advanced stage, cancer. If the patient cancer has marker that predict response to immunotherapy, and the way it works, it charges the immune system to recognize and get rid of the cancer cells. So it unmasks the tumor for the immune system to recognize it. And some patients with, stage 4 cancers, we can utilize immunotherapy for them. Targeted therapy, if you hear about it, it refers to basically targeting a certain mutation in the tumor. For instance, for colorectal cancer patient, they have what's called sometimes BRAF mutation, which is an oncogene, a driver mutation that keeps the cells of the cancer dividing rapidly. And these targeted therapies sometimes in the form of pill that your patient can take and inhibit this overactive enzyme and help control and suppress the tumor. Any questions?
I actually had a few questions that came in from someone that actually couldn't attend tonight, but I have 2 for you. The first one is, with GI cancers, is it more likely that the cancer will spread throughout the GI tract because these are, interconnected oftentimes? Is there a bigger risk for cancer spread because of the type of cancer, where it's located?
I mean, it depends. Some patient, even the pathology of the GI cancer, you have a well-differentiated tumor and poorly differentiated tumor. Obviously, you don't want to sit on the cancer. If you have a cancer diagnosis, you need to proceed, as soon as you can to get rid of it, whatever, treatment modality. So if a patient is diagnosed with cancer, I would say I'll see you 6 months later. There is obviously risk for progression. But every two patients are different. Like a colon cancer patients can have an indolent or slow growing tumor, and another patient with the same colon cancer patient can have a very aggressive disease, and with the one with aggressive disease can metastasize much faster compared to the other one. But they're all at risk of progression and metastases.
Okay, great. Thank you for that. And I do have one more. So when someone is in, if they've been given the all clear or they're given the watch, like the no evidence of disease, what are they supposed to watch for? Because these are cancers that typically don't have a ton of symptoms.
Correct.
What does monitoring look like? Is it a little different than
Yeah.
a different cancer?
Correct. So a patient, after they complete their treatment and they achieve remission called no evidence of disease after finishing therapy. That's great. We feel excited, and we hope that the patient will never recur. But we don't say the word cure until they finish 5 years of surveillance. And this surveillance during this period, we do, and depends on the cancer type, but we probably end up doing some imaging study every 3 to 6 months, especially the first couple of years. This is where the highest risk of recurrence. We do it, every a few months. We repeat images, and like for colon cancer patients, a year after diagnosis, they do get colonoscopy at year 1, at year 3, and at year 5. So we follow the surveillance by the NCCN guidelines. If the patient, while during this surveillance, start having symptoms, we pay attention to it. Like if I do a patient is not due for CT scan 4 months from now, and they're having weight loss, or they're having difficulty swallowing or constipation, or I'm concerned about the symptoms, then I get the workup done, obviously earlier. So you just need to be aware of the symptoms and keep in contact with the treating physician.
Awesome. Thank you. And then I have another one here. It looks like from Ella. Can metastatic breast cancer spread to the GI? And if so, how are you going to treat a metastatic cancer that has spread?
It can. It's not common location for the breast cancer to go to the GI system, but it can. And that essentially would be a stage 4 cancer of the breast cancer. And you treat it, you treat essentially the breast cancer, the metastatic breast cancer. And that's a separate, topic, but you look at the markers of the breast cancer, the estrogen marker, the HER2 marker, and then you come up with the treatment strategy for metastatic breast cancer that went to the GI.
All right, great. Thank you. Yep, that answered it. I'm just confirming. All right, it doesn't look like anybody else has any other questions. I will let you guys know, my virtual audience here, that if you do come up with any questions in the next, if you think of something or whatever, this chat will actually stay open for a little while. So you're welcome to put that there. And I'm also going to put my email address in the chat here. So if you think of something, I can certainly relay your question and get that answered for you. So there's my email if you guys need it. If nobody else has any questions, we'll wrap up for this evening. Thank you all for joining us. I really appreciate it. Oh, and one other thing too, if you guys want a copy of this PowerPoint, please let me know. Send me an email to that email address. I'd be happy to send that out. All right, awesome. Thank you, everybody. I appreciate your time.
Thank you, Ashley.
Have a good night.
Have a good one. Take care.